Good afternoon, Ms. Prescott.
Afternoon.
Now, you're talking to the people you see here, that's obvious, and the lawyers to your left, but there's a much bigger audience out there watching remotely. I don't know quite how many, but generally speaking, it's been about 100 or so this week. So they're the people who also need to hear what you have to say. Bear that in mind when you're answering the questions. The questions will be asked in a moment or two by Ms. Fraser-Butlin, but first, Mary will invite you to take the oath. Mary.
Please state your full name.
Elizabeth Emma Prescott.
Take the book in your raised hand and repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Yes.
Ms. Prescott, first of all, I'd just like to work through a brief overview of your career. You qualified as a registered general nurse in 1988, is that right?
Yes.
And you worked then as a staff nurse specialising in oncology nursing
Yes.
from 1989 until 1995.
Yes.
And then you became a thalassemia nurse specialist at the Whittington Hospital, and you've remained in that role since then.
Yes.
You also took on a hepatitis C nurse specialist role at the Whittington Hospital between 2006 and 2009.
Yes.
And we will come back to that in a moment. First of all, in terms of your training as a nurse, what were you taught about the risks of viral transmission in blood transfusion?
In my basic training in general nursing, I don't remember actually being taught anything about viral hepatitis at that stage. My knowledge came really more from media itself, hospital sort of infection control measures, and literally just reading up on papers myself.
And what were you taught about record keeping when a transfusion was given?
I think that was quite thorough. Obviously, it's vital to document everything that you're doing with the transfusion. So we would obviously correct prescriptions, correct documentation of collection of blood products from the laboratory, documentation of receipt of blood products onto the unit. Obviously, after the cross-checking documentation that it has been checked, patient observation documentation, how any issues during the transfusion. Post-transfusion, how the patients were prior to being discharged.
And when you were working in oncology nursing, so between 1989 and 1995, what involvement did you have in giving blood transfusions?
Not much at all. Very rarely. I was in solid tumours, particularly breast cancer and head and neck tumours, which on the whole didn't require blood transfusions.
So you then became a clinical nurse specialist in thalassemia in 1995. The inquiry's heard evidence about what beta thalassemia is, and there is an expert report dealing with it. But for those listening who perhaps haven't heard that previous evidence, could you tell us in layman's terms what beta thalassemia is?
Okay. Beta thalassemia is a genetic inherited disorder. Both parents have to carry the faulty gene, if you like, to pass that on to the affected child. So any pregnancy with mum has a carrier, dad has a carrier, there is a 1 in 4 chance that pregnancy will result in a thalassemia major child, so 2 inherited genes. It stems really from the years of malaria. So if you look at the malaria belt across the world, these tend to be where the countries that have been affected by thalassemia, because the thalassemia carrier, we believe, holds some protection against malaria. So the main countries would be really, it's not indigenous to North Europe, it's really coming down the Mediterranean countries, moving across then into the sort of Middle Eastern countries, and then across to the Indian subcontinent, and then across to the Far East. Basically the upshot is with these patients, they don't produce enough or any at all hemoglobin A, which is our adult hemoglobin. So this is the oxygen transporting mechanism that we have to get oxygen to the rest of our body. When you're first born, a baby majority of a baby's hemoglobin would be the hemoglobin F, the fetal hemoglobin, which is not affected by beta thalassemia. You don't need the beta globin for that production. So unless you're screening children, a child would be born, you wouldn't actually know that they have thalassemia until that F level naturally comes down. So usually around 3 to 6 months is when you'll first see that these children become weak and anemic. And they become pale, they may not be feeding, they're obviously unhappy, they're failing to thrive. So depending on the severity, because I should have mentioned this, there's lots of different mutations, lots of different types of that beta thalassemia, over 200. So again, depending on what they've inherited from mum and what they've inherited from dad will determine how severe their thalassemia is. Thalassemia in the old days used to be categorized into two main areas. One would be thalassemia major and one would be thalassemia intermedia. The thalassemia major would be those that at 3 months are not thriving, so they have no option but to receive blood transfusions. And thalassemia intermedia, not that long ago, would be termed as those who are managing to grow, managing to survive without blood transfusions. It's now become clear that that's not so clear-cut, and we don't have a clear definition between a major and an intermediate. So we now call them transfusion-dependent thalassemia and non-transfusion-dependent thalassemia. And the non-transfusion-dependent thalassemia really need very careful monitoring, because just because they're living doesn't necessarily mean that they're thriving or they're not going to get long-term complications. For the sake of the inquiry, I look after thalassemia, the old thalassemia major, the transfusion-dependent. So all of these chaps require blood transfusions in order to survive.
And roughly how many patients are treated within the Whittington Hospital?
We have 140 regular transfusions, so those are guys that actually come to my day unit every 2 to 4 weeks. And then because we are a tertiary centre, we have probably between 50 and 100 that come from other parts of the UK, but we do not transfuse them. They just come for specialist advice. But that's changed now with the new hemoglobinopathy coordinating centres and so satellite centres. So hopefully these patients will be managed more locally and get the care they need in their own centres.
Can you tell us broadly what your role at the Whittington Hospital involves, particularly on a day-to-day basis?
Day-to-day basis, basically I'm the manager for the transfusion day unit. So I'm there pretty much with my nursing colleagues, the first point of call for these patients. So it's very important that, obviously, from an observation point of view, we're the first really to actually see whether there are any problems arising with these patients, whether it be clinical or whether it be psychological. So they can't, obviously, 140 patients cannot see the consultants every 3 weeks to monitor their blood results and check how they're taking their medications. So that's a very important role for me. So each time a patient comes for their pre-blood test, which I would arrange, it's obviously my responsibility to check that is everything all right? Is their kidney function all right? Is their liver functioning? I also monitor their iron, and I should have probably mentioned that in the first bit. Thalassemia isn't so straightforward, unfortunately, as just having blood transfusions. Every time you give a blood transfusion to anybody, you give between 200 and 250 milligrams of iron. Our daily intake is 1 milligram, and our daily excretion is 1 milligram. So if you have an average man having 3 units of red blood cells every 3 weeks, he's having between 600 and 750 milligrams of iron in a 3-week period. So as the time goes on, after a year or so, this iron becomes, it's unsafe, if you like, and it's unbound. And this is what creates the problems for our thalassemics in developed countries where we have the blood and to keep them alive. So unfortunately, there's no natural way of getting rid of this iron, so we have to mechanically get rid of it with what we call iron chelating agents. Up until the sort of 1990s, the only treatment available is a drug called desferrioxamine, which cannot be taken orally. It has to be given either intravenously or subcutaneously, and it cannot just be given in one quick injection. It doesn't work like that. It has to be slowly infused, mopping up the iron as it goes through the body. So usually the treatment is given over around 10 to 12 hours over over around 5 to 6 nights a week. But it's painful. It's you imagine a small child having this thick sort of syrupy infusion going into their tummy, and it's not optimal. And if you're looking outside of the UK, it's also quite expensive with all the syringes and the medication. So a lot of patients up until the 1990s were dying at a very young age of iron overload, particularly iron in the heart. It also affects the liver, and if you don't treat the iron appropriately, you will get fibrosis, cirrhosis, and eventually cancer of the liver. It also affects the endocrine glands, so your pituitary gland, which is our gland that's responsible for our growth, for our energy levels, for our hormones, for fertility. Also affects the pancreas, which if that gets damaged, we're now looking at diabetes. So iron overload in the developed countries is the major killer in thalassemia. Moving on to the mid-1990s, a new novel tablet form of chelator came in, not without its complete side effects, but a very, very welcome extension to destrol. And this drug is given 3 times a day, every day. And then moving into the mid-2000s, we have now had a once-a-day formulary, which is obviously far more tolerable to these patients. But again, as with most things, it's not 100% without its side effects. And even those who do tolerate it, for one reason or another, compliance or concordance to taking the medication is not always 100%. So we're still having battles with treating iron overload. And other patients have allergies or severe side effects. So again, that's an issue. So going back to your question, a major part of my role would be to monitor the compliance, the issues, the side effects, their toxicities, the dosage, reduction or increase of these chelators. And then obviously the psychological support, because as you've heard, it's not particularly pleasant treatment. So they do need support. They do need sometimes to sort of discuss issues. Maybe we can, sort of work out ways to resolve it. So that I see as a very major part of my role. Also education. I do a lot of nursing and medical education, not just here, but also in other parts of the world. We've been very fortunate to travel to other clinics and develop services abroad. What else? Clinical research. We've been an active centre in clinical research for many, many years, particularly revolving around the iron overload issues and the iron chelation issues.
So in terms of the transfusion, the provision of a transfusion to a patient, who would decide when a transfusion would be given? Would that be your decision or would it be a clinician's decision?
It would be a clinician. As I say, this is from birth. Even in the non-transfusion, the milder phenotypes, usually they are presenting in childhood in some form or another. So at the Whittington, which has been going on for many years, we don't just have a paediatrician who's generically looking after kids. It's a paediatrician with a thalassemia doctor, haematology consultants. So they would be the ones who, usually the patients are referred either by a GP or by a local hospital. And usually it's a watch and wait sort of thing to begin with. How is the child thriving? What's happening? Obviously, get the genetic profile to see. But it would be ultimately the haematology consultant and the paediatric consultant.
And when they make the decision that a transfusion needs to be given, would they decide that we need to give one today, or would they decide, right, we need transfusions this regularly with this patient?
Yeah, I think by the stage you've decided, when you know that this child now is transfusion dependent, then yes, this is ongoing, so that the family would be prepared that this is now, it's very rare that you can say, well, we'll give one transfusion, but the child's going to be okay, unless there was a specific reason why, a virus or something that suddenly plummeted that child's hemoglobin. But on the whole, you're making really a lifelong plan for that child at this stage.
So each time a patient comes into clinic and sees you, comes to the day unit, would they also see the doctor to decide, yes, there's going to be a transfusion today?
No.
Or would it be part of a protocol for that patient?
No, it's part of the protocol. I mean, obviously, every patient is individual. Even if you had a patient who's inherited exactly the same mutation as their Greek Cypriot friend, they're going to be different. They're going to be different in their requirements. They're different in their lifestyles. They're different in their body weight. They're different in all sorts of ways. Some patients had this, in the old days, we used to routinely remove the spleen because, giving blood wasn't appropriate, or we didn't want to give so much blood. We had no way of getting rid of the iron. So by removing these enlarged spleens, we were reducing the amount of red blood cells that they needed. So those patients tend to have slightly less blood transfusion requirements than our youngsters that we really do want to keep the spleens in. So again, it's an individual care package, if you like, for each patient. And this can change also. You know, so a patient may, as a child, go every 4 weeks, but as they're getting older and they're getting bigger, their hemoglobin may drop after 14, 15, 21 days. So we adjust our package to suit that individual patient. But on the whole, you know, once they're adulthood, it doesn't tend to vary too much. If you come in for 2 units every 3 weeks, that's usually your pattern.
And what's the usual pattern for people? Obviously with some variation.
Yes, it's variation. So I would say if you were to average it out, it's probably 3 packs of red blood cells every 3 weeks, but some 2 units and occasionally some 4 units, but depending on various variables.
And would those units be given as a day patient, or do people come in for longer
No,
stretches?
we try and make it, because this is part of their life, and these are busy working mums, dads, you know, nurses, doctors, you know, themselves. So we try to make it as streamlined as we possibly can. We try to fit in with their diaries, you know, hemoglobin's allowing. They will come in the morning or afternoon. And with those now, we audited this along with UCLH, and we found that it's quite safe. The red blood cells, they're leukocyte depleted, the reaction, transfusion reactions are very, very minimal, if at all. The unit sizes it's packed, they're quite small. These patients, we know if they've got healthy hearts, healthy kidneys, that they can tolerate 3 units of blood over a 3 to 4 hour period. In the old days, they may have been admitted for 24 hours, which is a heck of a burden if you're trying to get on with a normal life. So it's very much an informal, you come in, you have your blood. If a patient says, I feel uncomfortable, I'd rather have it over 6 hours, that's completely fine. But the idea is we're trying to minimise any disruption to their lives.
And in terms of the group of patients who are not transfusion dependent, what's your understanding of the clinical indicators for needing a transfusion? Does it sometimes happen that they do need a transfusion?
It can do. I don't want to soak too much because I don't have so much experience with the non-transfusion dependent. But obviously sometimes for whatever reason they will drop their hemoglobin, and thereby, you know, if it drops to a level, you wouldn't, if they suddenly drop from 90 to 80, I don't think any clinician is going to say rush in with a transfusion. It's a watch and monitor. But if they severely drop, then yes, you know, substitution is certainly not what they need. So yes, they may do something like parvovirus or something that we may plummet it. And occasionally, somebody has been non-transfusion dependent, and for whatever reason, the clinician will notice that actually they may be getting increased pressure in their lungs, or their heart may be running into issues, or they may be getting expansion of the bone marrow to a degree which is deemed to be, you know, clinically not safe for that patient. So they may then switch over to transfusions.
So for those that need transfusion only irregularly, how is that administered? Would they come into your day unit, or would they stay at a sort of standard haematology centre?
If it was the Whittington, we have a handful of the non-transfusion dependent. They would be very closely monitored by the haematology consultants, and it would be the haematology consultant who made the decision of whether or not to transfuse.
Could we turn to WITN 6979003? It'll appear on your screen. We can see here a document from the Whittington, which is the blood policy, and it's dated from October 2019. We can see it's version 6. Do you recall when the sort of first set of guidelines were produced in the Whittington?
There would have been guidelines when I was there at 95. I cannot recall, unfortunately. You know, I can't imagine it is greatly different from the one we actually see now. But unfortunately, I can't recall exactly.
But throughout your time in practice, as far as you're aware, there's been a set of guidelines.
Absolutely,
in
yes.
relation to blood policy.
Yes.
Thank you. You can take it down. Thank you. Just in terms of real practicalities of when a transfusion's given to a patient, what would be written in the patient record in relation to the giving of that transfusion?
When they first start or ongoing?
Well, both. If we start with when they first start.
So when they first start and they're being seen by the haematology paediatrician or if they are a non-transfusion dependent and being seen by the adult haematology consultant, obviously everything would be explained to that patient. So you're looking at the benefits of the blood transfusion. So in the case of the non-transfusion dependent, to maybe reduce this pressure in the lungs, or maybe to reduce this excessive bone marrow expansion, maybe to improve quality of life, but also the cons of a blood transfusion, which iron overload obviously being the main one nowadays, and obviously explanations on how we would treat the iron overload. Alloimmunization is a huge issue with these patients. As I mentioned, the countries where these patients originate from, we know that the majority of donors in the UK are from white, Caucasian, Northern European. So there is a risk of when I say alloimmunization, I mean developing antibodies against the blood that they're receiving. The more antibodies they develop, the more difficult it is in the long term to find safe, very, very 100% cross-matched blood, which is what we aim to do at every time. And all our patients, their blood is, we genotype them and phenotype them on at regular intervals to make sure we're giving the correct blood for them. Bacterial infection is a risk. It shouldn't happen, but it's something that we would explain. And even nowadays, viral infections would still be, that there is, albeit exceptionally slim, but it would still be discussed with them.
And just staying with that first interaction and the first time transfusions would be needed, you were obviously only involved in thalassemia care from 1995, but what's your understanding of what your patients were told previously about viral risks of transfusion?
I obviously wasn't there, but they would have been informed from that there is a risk of transmission of hepatitis C, hepatitis B, and HIV. Even in those days, I don't know exactly when the hepatitis B vaccination came out, but it certainly was out when I started, and patients were vaccinated against hepatitis B, anybody prior to starting a transfusion programme, and we still monitor their antibody levels each year to make sure that they're up to date with booster vaccines. As far as I'm aware, all patients would have been informed that there was a risk of transmission in those days.
And have you had conversations with current patients about what they were told historically about viral
No, I
transmission?
haven't. No.
So it's just a sort of assumption that that's what they would have been told.
Yeah.
Okay. And then once you come to the sort of frequent transfusions, what information is given to a patient on each occasion that they then receive a transfusion?
Probably not a great deal, because this is something that is literally happening every 3 weeks for them. Iron, as I say, is the major issue, so we constantly are updating them on what their iron levels are doing. I don't think, from my point of view, things have changed dramatically from the transfusion perspective. The only thing that's changed more recently is the audit we did regarding the actual how quickly, if you like, they can have the blood, which is a benefit to most of the patients. But I think and they're expert patients as well. I think it's very important to remember that, these patients have lived with this all their lives. They're very, very educated group. So, and we're very open to discussion if anybody has any particular concerns, whatever it may be.
And in terms of providing information and obtaining consent for transfusions, again, I'm aware you only became a specialist in 1995, but from your discussions, if you've had any with the patients, has there been any change in relation to the consent process for transfusion?
Not as far as I'm aware that there's been a change. As far as I'm aware, that the consent would have been the same. Consent form would have been completed and signed by the parent or guardian if it was a child, or by the patient themselves, and that's obviously documented in the notes. The discussion with the patient would have been documented in the notes, and that remains the same to the day.
And what happens when a patient becomes an adolescent? Perhaps their parents have given consent as a child. What happens in relation to information and consent for those patients as they reach adolescence?
Very good point. I actually cannot answer that. I don't know whether the consent is resought. By the time they come to me to have transition, they're actually they are adults by the time I think probably more information is constantly given to them, and we do a lot of educational seminars for these patients along with the UK Thalassemia Society. So really we want these children and these adolescents to become the expert patients and to, you know, so they're very, very informed about their treatments, even from a young age. But I'm not sure whether the actual consent is
And you spoke a moment ago about the psychological burden of the illness, of the disease. Can you tell us more, of the condition I should say, can you tell us more about what that is like for patients with thalassemia?
It's improving, thankfully, a great deal, but it in some parts of the world it actually was called a stigma. And you'll see, you know, people, older generation will still refer to thalassemia as the child with the stigma, and that sits with these guys even when they're in their 50s. Many of the patients were told, so we're looking at patients now in their 50s, and they were told, their families were told when they were, you know, 6 or 7, oh, don't bother sending them to school, they're not going to live long enough, just spoil the child, let the child. So some of them didn't get the education. Some of them were actually put in special schools that they used to for, so if you had any disability, if you were deaf or I think diabetes, I think they classed, and thalassemia, so some of the patients were, so again, they were sort of discriminated against in their eyes. In some families, you know, when you're looking at sort of introduced marriages, you'll see that some people don't want to disclose that there's thalassemia in the family. So again, it's sort of evolving around this stigma that there is a problem in that family, there's a genetic problem. So that still sits strong in some of the patients. A lot of barriers have been bashed down, and I think there's a lot more awareness out there now, you know, particularly in the sort of, in this part of the UK, there's a, you know, people are not frightened so much to say that they have thalassemia. But, you know, throughout the years, you know, I'll give you an example. One of the patients always jokes that he has to pay insurance on absolutely everything, but he can't get life insurance. You know, trying for them to get a mortgage, you know, that sort of thing. So we were on the one hand telling them, you go to school, you go to university, you do whatever you would have done normally, you live a normal life. But then they're going out into the real world and they're not being able to live a normal life. So there is discrimination, and that to a certain degree still, and the patients have definitely said that they feel stigmatised.
In terms of hepatitis C, are you aware of whether routine testing for hepatitis C of all thalassemia patients was carried out at the Whittington before you arrived?
It definitely was before I arrived. I'm not sure when it was actually introduced. Knowing the lead consultant of the time, she was incredibly, you know, so proactive. I can imagine as soon as any risks were alerted to, that the patients would have been screened.
So you're assuming it was early,
Assuming,
but you know that they were certainly tested before 1995.
Yes, certainly, yes.
Do you have any awareness from perhaps conversations with patients, what they were told, what information was provided to them before they were tested for hepatitis C?
Not then, no.
And in your statement, you've said that there were 9 Whittington thalassemia patients in total who were hepatitis C RNA positive, and then 6 other patients were referred to the Whittington from other UK centres.
Yes.
But since your statement, I think you found an old presentation that gave a different set of figures.
Yes.
And you think that, in fact, 25 patients were identified as hepatitis C positive. Is that right?
In 1995, when I started, or not necessarily then, but when I started to get involved in the hepatitis management, I set up my own database. We had 9, as you say, Whittington, 6 from other UK centres, and I think it was 5 from who had come in from abroad. You know, when I presented in the BSH in 2005, after we did the pegylated interferon on these patients, and I clearly said in a slide there that we had 25. Previously, we'd had 25 patients. There weren't 25 involved in that pilot study. Now, that figure I would have got from the existing probably haematologist database or the hepatology database. But I don't know who those missing 5 patients were, I'm afraid.
And within that 25, some of those would be patients who have come in from abroad.
There were definitely 5 from abroad. I don't know about those 5 missing patients, but 5 out of the initial 20 were from abroad.
You then became a part-time specialist hepatitis C, clinical nurse specialist. How did that come about?
Well, I obviously was working very closely with the pegylated interferon, the yearly trial that we did on the 11 patients that at the end that remained antibody hepatitis C positive despite previous interferon treatments. So I'd been working with the haematology and hepatology consultant with this, and I was closely monitoring them on a weekly basis throughout this year. So working closely, obviously, with the drug company as well that was providing the interferon, and they were very supportive in things that they could offer. Then our gastroenterology department in the hospital were trying to there were a lot of general hepatitis C patients out there that weren't really, they didn't have the resources or the time to actually, put in a proper program. So they wanted somebody to sort of run alongside them at the clinic to try and get as many of these patients treated as well. So the Shearing Plough, the drug company, sponsored my post with the hospital for 1 day a week for 3 years to try and get as many of these general hepatitis C patients. So it's 4 days thalassemia and 1 day as a hepatitis.
So just tracking back to when you just had the beta thalassemia role, during that role, were you also providing support to patients undergoing hepatitis C treatment?
The general patients.
The beta thalassemia patients?
Sorry, clarify that again.
So before you took on the hepatitis C specialist role, and you just had your thalassemia role,
yes,
were you also then supporting thalassemia patients receiving hepatitis C treatments?
Yes.
And so were all patients with beta thalassemia at the Whittington who had hepatitis C seen by you in dealing with their hepatitis C?
Along with the haematology and the consult. But we found with this group, because we know with the interferon in the general population without thalassemia, that it does drop their neutrophil, the bacteria-fighting cells, and so they needed to be monitored. And I think the general protocols were they were monitored after 2 weeks and then monitored monthly. We found because our patients, either because they had slightly enlarged spleens, which were chewing up their neutrophils more quickly than our spleens would, or they were taking one of the oral chelators, which also coincidentally had the side effect of dropping the neutrophils. Now, obviously, if you drop the neutrophils too low, you're putting that patient at extreme risk of severe infection and potential death. So we decided that initially we would monitor them weekly to make sure that they were safe on the interferon drug. We found that actually they were dropping their neutrophils very, very rapidly. I think 7 out of 11 were frequently dropping the neutrophil counts. So throughout that year, I continued to monitor them on a weekly basis to make sure, check their bloods to make sure that they were safe in the safe zone. And there were also other issues, the psychological impact of this treatment. One of the other things which was problematic is that the tablet form of antiviral, the ribavirin, even in the non-transfused population, caused what's known as hemolysis, so an early destruction of the red blood cells, which was a bit disastrous in our patient group that also had this hemolytic anemia. So again, that was very important to monitor weekly to make sure the hemoglobins weren't plummeting, and we obviously having to transfuse them instead of every 3 weeks, it might have been every 8 to 10 days. So again, a lot of active monitoring to make sure that they were safe going through the treatment.
So in terms of the thalassemia patients that you were seeing who were having their hepatitis C treatment, you saw them weekly?
Yes.
And the haematology consultant saw them regularly?
Now, how we did this, we used to run an evening clinic on a Thursday. This was because the patients are working, they're in school. We didn't want them to come in on a Tuesday afternoon. So for the general thalassemias, for their usual screening clinic appointments, they would come on a Thursday evening. So I would set myself up in a clinic room next to the haematology who was running her general thalassemia clinic. So if there was any concerns, or if the patient just wanted to have a talk to the haematologist, or I was concerned about anything that they were going through, the side effects or their blood results, we were doing a sort of one-stop shop, if you like. So that's how we reviewed them. So they would come in Thursday clinic, primarily to see me, because some of them didn't really need to see the consultant every week, but there was a consultant haematologist, the lead consultant, there if there were any worries.
And was a hepatologist available as well?
Not in that clinic. At that time, we didn't have we had a gastroenterology service, but not a specific hepatology service at the Whittington. The Royal Free Hospital is a renowned hepatology service, so we had very close links. All our patients were reviewed prior to starting treatment by the hepatologist, all the sort of preliminary investigations that they needed, and then they were reviewed depending on need, but I think it was on a 3-monthly basis. And that goes on to this day. Any patient who did sustain liver damage, which was unfortunately the majority, would still be seen by the hepatologist at the Royal Free if need be.
And you've spoken a little bit about the particular difficulties in providing treatment for hepatitis C for those with beta thalassemia. You've mentioned the neutropenia,
Yeah.
And the difficulties with enlarged spleens. What else did the interferon cause difficulties with in relation to patients with thalassemia?
Interferon is an absolutely horrible drug in my opinion. I think it's probably the worst drug I've ever had to use with patients. It has terrible side effects. It can turn a very mild-mannered person into spontaneous bouts of aggression through no control of their own. It causes severe depression. It makes you extremely tired, very, very fatigued. And you think about their hemoglobins also, they have anemia, they feel tired, for probably a third of their life as it is. It causes weight loss, and our thalassemia group on the whole tend to be on the slimmer side. So one guy, I think, dropped down to about 41 kilograms from about 58 kilograms, and he was literally wasting away. He's no energy. He's feeling absolutely lousy. So it was a horrible, horrible treatment for them to go through, and it was a year long, and then the side effects tended to last for the period after the treatment as well.
And in relation to the impact of liver iron on the success or not of the treatment, what can you tell us about that?
Well, obviously liver iron on its own, taking away any virus or any other sort of aggravator, if you don't treat it appropriately and you allow it to mount up, will cause scarring of the liver, which will eventually turn into cirrhosis, which will eventually potentially turn into a cancer. You put something like a virus on top to aggravate that liver, then you're speeding up that process 2, 3, 4, 5-fold. We also know from previous studies that the response to interferon treatment, or getting in at the liver and attacking the virus, if you have a build-up of iron in the liver, then your response to the antiviral treatment is not going to be as good as well. So they were really having a double whammy, really. So again, before we started the treatment, we had to sort of intensively chelate them to try and get the livers out to give them the best possible chance of clearing the virus. But many of these patients were in their 30s at this stage. They'd contracted the virus possibly 20 years before we started, maybe even longer, before we started it. So their livers were damaged at that stage. So it was imperative that we try to, get that virus under control.
And what was your experience of the success of the treatments in the beta thalassemia group?
It wasn't as good as the general population. I think 4 out of 11 initially responded. This is the genotype 1, so the core group. 2 of them later relapsed after 3 months stopping treatment. So we had 2. I think when you look at the large studies in those days with the interferon and pegylated interferon and ribavirin, they had a sustained rate of 48%. So ours was actually significantly lower. And I think that's probably a few reasons. One, that we probably had issues with the liver, so were we optimally getting that virus? But probably most importantly is because we couldn't optimally treat them, because we were having to dose reduce majority of the time. I think 7, looking at the slides, 7 out of the 11 patients, we frequently had to half the dose of the interferon because of the neutrophils, and there were 2 patients who dropped their platelets significantly, so they were constant. I think there was only 1 patient who sustained the optimal dosing throughout the whole year. All the others, and I think the majority of them were probably only getting about 50 to 60% of the optimal dose. So they weren't really standing in a very good stead.
Prior to treatment being started, what were patients told about the likely side effects of the interferon?
All of these patients who started the treatment that I was working with had already previously been on the intermittent interferon. So the standard treatment before would be the non-pegylated form. So this was given as an injection 3 times a week, and it was given in combined with ribavirin. and it was given for 6 months. The pegylated was a once a week, sort of longer acting injection, and it was given for a year. So the patients were, but when I was treating them, were well rehearsed. They knew exactly what was ahead, and not one of them, I would say, would, took it on lightly because it was such an awful treatment. But they were obviously informed, reiterated again about the side effects, about the risks involved, about the importance of, proper monitoring and, and reporting of side effects.
And from your conversations with those patients, did you have any sense of the information that had been provided when they first had interferon, whether they'd been prepared sufficiently for the side effects the first time round?
I think, knowing the team that I worked with, they definitely were. We knew what had happened in the general population. We knew what the side effects were very well documented. Also, again, they were monitored so regularly. There was a lot of, they had a lot of interaction to sort of report back how they were feeling, how they were coping. So I think they were giving, more than adequate information.
And in terms of your role with patients, and you've talked about the side effects, including significant depression and other mental health impacts.
Yeah.
How much of your role involved psychological support of patients going through the treatments?
It was a lot of my role. I remember those Thursday clinics, even though they were 16, 17 years ago, very, very clearly, because you seeing patients who were so sort of upbeat normally, and they were coming in and they're absolutely drained. At least two patients lost relationships with partners to that time because of either the way they were feeling or maybe because of sort of aggressive outbursts. So a lot of time was spent with them, and I really sort of gained a lot of insight into it.
And did you have any specific training in psychological support or counselling before you started dealing with the patients?
Yeah, in the Royal Marsden, I did a psychosocial counselling sort of module there, not particularly in relation to anything like that, but generally about sort of counselling skills.
And was there any specialist psychological support and counselling
Yes.
available to those patients?
We had, and still do, have a psychologist who's dedicated to the thalassemia and sickle group, and I think they have about 4 sessions a week at the Whittington. So any patient, and obviously she was sitting on the MDT meeting, so it's very, very, knowledgeable about the thalassemia generally and what they're going through, and we would have, gender up, if you like, on what was happening with the hepatitis patients. So any patient who really was struggling or wanted to had easy access to our psychologists.
And would that require a referral from you, or
Yes.
could they access that themselves?
No, it would be a referral from us, but it would be a relatively quick turnover. As I say, the psychologists sat in the MDT meetings, so these were, where we discussed patients, any issues. So it would have been picked up then, and the next available slot they would have been seen. And they would also come to the transfusion unit to see them, so that they didn't have to drag themselves out on a Thursday when the transfusion on Tuesday. So we'd arrange for them to come into the quiet room, and then the two could have their session together then.
You spoke a moment ago about the stigma involved in having thalassemia, and the inquiries heard evidence about the significant stigma involved in having hepatitis C.
Yes.
What was your experience of that in the patients that you saw?
I think it's tremendous, and I think it still is, the impact. Only the other day I was asking a patient why, they hadn't sort of come forward to the inquiry, and the first thing they said was, I don't want people to know I had hepatitis C, and I understand that. They've lived through their life, as I mentioned, with the stigma of thalassemia, and in some cases actually hiding it from their partners' families or from their work colleagues, and then just, to actually now, well, I'm out there, I've got hepatitis C on top. And I've even had patients say that they felt dirty with hepatitis C. So tremendous impact psychologically, and I think still to this day, very few of them would openly discuss that they had hepatitis C. I've also had patients say to me, that's a part of my life I don't ever want to revisit. And that's quite, considering what they've been through their life, that's the bit that sort of really does stand out as the tough bit.
From your perspective as a specialist nurse, how important do you think your role was to helping patients get through the hepatitis C treatments?
Well, I think obviously it was a completely team approach, and I think all of us had parts to play. And fortunately, with the Whittington team, it always has been and will be a very close-knit group, and everybody had their own part. I do think that the nurse role was significantly important simply because of point of access. You know, I'm always there, if you like, where obviously consultants have their busy clinics, they have other things, they're contactable and they're always eager to be available. But I'm a point where basically everyone knows where I am. I would see them once a week. So I think it was an essential part of the role. And now you'll see that there are more and more of these nurse supportive roles in various disciplines, you know, where patients are having issues.
If a patient didn't clear the virus in that first treatment, can you recall what practices or policies were in place in terms of additional courses of treatment?
Well, after that final course, until the recent antivirals, there's been nothing in between. So, and 9 out of that 11, so 9 out of the original 25 were now an ageing population, if you like, with liver iron preceding many, many years. So damaged, we knew that they had fibrosis and some of them had cirrhosis. We've had patients who've gone on to have a liver transplant directly because of the hepatitis C combined with the iron. We have lost 4 patients in that out of that cohort from liver-related problems. We also have 1 or 2 who we know have esophageal viruses as a secondary from the virus and iron overload. So they're still not without their problems. So hepatology follow-up is essential. Obviously, the haematology follow-up they get all the time. So it has remained at the Royal Free Hospital and the liver unit there, and they are under surveillance, you know, throughout they've been, and up to this day.
So whether a patient cleared the virus in the first tranche or whether it required the direct antiviral?
Yes. So we have, there's one girl who, her liver isn't too bad, but she did have some evidence of liver disease. Now, she was in the very first cohort she cleared. She was a genotype 2. It was nice and smooth, but she had already sustained, and she would have only been in her 20s then. She's now coming up to 50. She will still be, we still will we ultrasound our patients for other reasons anyway, but we do the hepatology screening, and she still sees the Royal Free team, I think probably on a yearly basis. We also now have the Fibro Scan, which has replaced the liver biopsies. So again, all these patients would be routinely screened with the Fibro Scan to see. Fortunately, those who did sustain damage, as long as we've kept their iron level, they don't seem to have progressed, provided they had cleared the virus, thankfully.
So that liver screening is for both the hepatitis C damage and also the iron overload issues?
Yes, yeah.
Thinking then about your broader hepatitis C nurse specialist role, the patients you were seeing in that clinic, were there others who had contracted hepatitis C through transfusions?
There was only one I remember. I think the majority were through drug use at some point. There was one patient that the only risk factor we could find, I think, was a transfusion in Egypt several years before that.
And you mentioned sickle cell patients. We heard evidence this morning about sickle cell patients. Did you see any sickle cell patients who had contracted hepatitis C and required treatment?
No, I don't primarily look after sickle. I do look after the sickle patients that are being transfused. In the old days, we would do what we call manual exchanges, and they would come to our transfusion unit. We now have the automated exchanges, and they came. I don't know of any, and I asked our senior consultant who'd also worked at UCLH. She hadn't seen the sickle patients. And when I asked her why we thought this was, I think transfusions back in the day, pre-1990, weren't so widely used in our experience in the sickle population as they are now.
But as a hepatitis C clinical nurse specialist, you didn't see any sickle cell patients?
No, they weren't referred. No, there wasn't any referred.
Finally, when a patient with thalassemia and hepatitis C was seen by you, were you involved at all in telling them about the ex gratia financial assistance schemes?
I was not really involved. I was aware of it. The UK Thalassemia Society, which is the UK charity for more than a charity, the tremendous amount of knowledge that they pass out there and awareness. They were heavily involved, and they were literally sort of information givers to all the UK members. So I think that's primarily, I think the consultants also were giving, in the clinics, were giving out the information about the funds as well.
So those are the questions I have for Ms Prescott. I should just ask for a break to see if there's anyone behind me who has questions that they'd like me to put to her.
Yes, of course. This is to give people who are represented and are core participants, their representatives are entitled to ask through council questions of you, if any arise from your evidence so far. So we'll take a break to allow them to forward their questions to council. Now, this is a break. You're giving evidence. The rule is that you must not discuss anything you've said already in evidence, or for that matter, discuss anything you think you might yet be asked about what you've been talking about. But you can talk about anything else you like.
Thank you.
Now, we'll take a break. How long do you think you might need?
Probably just 10 minutes, sir.
Okay. Well, we'll take a break. Let's say not before 3:05. I say not before 3:05 because if there are more questions than council anticipates, we'll start just a little bit later. But we won't start before 3:05.